Welcome to our comprehensive overview of nerve entrapment syndromes in the foot and ankle. These conditions, often called tunnel syndromes, occur when nerves are compressed within anatomical structures like bones, muscles, or fibrous tissues. Despite their significant impact on quality of life, they are frequently underrecognized and misdiagnosed. In this video, we'll explore the causes, symptoms, diagnostic challenges, and management strategies for these syndromes. Our journey will help you understand why timely recognition and intervention are crucial for preventing permanent nerve damage and restoring function. Tunnel syndromes refer to conditions where peripheral nerves are compressed as they pass through narrow anatomical spaces. In the foot and ankle, that can happen due to trauma, anatomical variations, repetitive strain, or systemic conditions like diabetes. The result is a range of symptoms, from burning pain and tingling to motor weakness. Understanding these syndromes is essential for both patients and healthcare providers, as early diagnosis can make a significant difference in outcome. Let's delve into the mechanisms behind nerve entrapment and why these syndromes are so often overlooked. Peripheral nerves in the foot and ankle are responsible for transmitting both sensory and motor signals. When these nerves are compressed, the resulting symptoms depend on which nerve is affected and whether it carries sensory, motor, or mixed fibers. For example, sensory nerve compression leads to tingling or numbness, while motor nerve involvement can cause muscle weakness or difficulty moving the foot. Recognizing the difference is key to accurate diagnosis and effective treatment. Next, we'll look at why these symptoms can sometimes be mistaken for other conditions. Nerve entrapments in the foot and ankle are often missed because their symptoms mimic other common conditions, such as plantar fasciitis or tendinopathy. Patients may present with sharp pain, abnormal tingling, or even muscle weakness, which can be attributed to a variety of causes. This overlap makes differential diagnosis essential. A thorough clinical evaluation, including patient history and physical examination, is the first step in distinguishing tunnel syndromes from other disorders. Let's explore the diagnostic process in more detail. Comprehensive clinical evaluation is vital for patients with neurovascular symptoms in the foot and ankle. This includes taking a detailed history, performing a physical examination, and using adjunctive tests when necessary. Electromyography can help, but its reliability varies depending on the examiner and the nerve being assessed. Additional tests, such as imaging or nerve conduction studies, may be needed to confirm the diagnosis and rule out other causes. Accurate assessment ensures that patients receive the right treatment at the right time. Treatment of tunnel syndromes targets the underlying cause of nerve compression. Conservative measures such as rest, physical therapy, orthotics, and anti-inflammatory medications are often the first line of defense. If these fail, surgical intervention may be necessary to decompress the nerve. The choice between conservative and surgical management depends on the severity of symptoms, the underlying cause, and the patient's response to initial treatment. Timely intervention is critical to prevent irreversible nerve damage. Conservative treatments for nerve entrapment syndromes include immobilization, rest, therapeutic exercises, heat application, and anti-inflammatory medications. Monitoring the patient's response is crucial, as persistent or worsening symptoms may require escalation of care. Corticosteroid injections can provide rapid relief in some cases, but repeated use should be approached with caution due to potential side effects. Clear treatment timelines help avoid delays that could impede nerve recovery. Let's look at when surgery becomes necessary. Surgical intervention is considered when conservative treatments fail to provide adequate relief, or when there is a clear anatomical cause of nerve compression. Procedures may include decompression, neurectomy, neurolysis, or even osteotomy to expand the tunnel space. The goal is to relieve pressure on the nerve and restore function. Early identification and appropriate surgical management can help patients regain daily function and prevent permanent damage. Now, let's examine specific nerve entrapment syndromes in detail. Sural nerve is a primarily sensory nerve that can become compressed at various points along its pathway, especially in runners and those with recurrent ankle sprains. Compression leads to neuropathic pain, burning sensations, and heightened skin sensitivity. The sural nerve's anatomical path, running behind the lateral malleolus and alongside the Achilles tendon, makes it prone to compression or traction injuries. Recognizing sural nerve entrapment is crucial, as it is often misdiagnosed as Achilles tendinopathy. Sural nerve compression can result from soft tissue growths, scarring, ganglia, surgeries, or vein inflammation. External factors like tight footwear or casts can worsen the issue. Repetitive activities such as running increase strain on the nerve, while repeated ankle sprains can lead to fibrosis and entrapment. Patients often report sharp pain or unusual sensations in the lateral foot and ankle, but clear physical indicators may not always be present. Accurate diagnosis is essential for effective treatment. Diagnosing sural nerve entrapment involves clinical examination for tenderness and swelling, especially behind the lateral malleolus. Passive inversion of the ankle can reproduce pain, and sensory disturbances like hypoesthesia or hyperesthesia are common. Tinel's tests may not always be effective, but localized pressure can worsen symptoms. Electromyography can provide additional information, though abnormal findings are seen in only some patients. Differential diagnosis should include other neuropathies, such as sciatic nerve entrapment. Initial treatment for sural nerve entrapment focuses on conservative methods, such as cold therapy, anti-inflammatory medications, and removing external irritants like poor-fitting footwear. Physical therapy can help mobilize the nerve and reduce compression from fibrous adhesions. Ultrasound-guided corticosteroid or local anesthetic injections may provide relief. If conservative measures fail, surgical options like neurolysis or fasciotomy may be considered. Early identification and treatment are key to restoring function. Deep peroneal nerve, DPN, also known as the deep fibular nerve, is a significant branch of the common peroneal nerve. DPN injuries are common in athletes, especially runners, football players, and dancers. Compression can occur as the nerve passes through the ligamentum cruciform and inferior extensor retinaculum. Symptoms include burning pain, tingling, and motor problems like difficulty lifting the great toe. Diagnosis often involves clinical tests and electrodiagnostic studies. Anterior tarsal tunnel syndrome is characterized by both sensory and motor symptoms. Sensory issues may involve hyperesthesia or hypoesthesia between the first and second toes, while motor problems can hinder toe lifting and cause muscle atrophy. Burning sensations often intensify with activity and may persist at rest. Everyday activities such as pressure from shoelaces can trigger discomfort. Diagnosis includes Tinel's sign and the squeeze test, helping differentiate this condition from other neuropathies. EPN compression can be caused by osteophytes, synovial cysts, ganglia, anomalous muscles, fractures, and inflammation. External factors like high heels, tight shoes, and repetitive trauma can aggravate the issue. Neuromas or aneurysms may also restrict tunnel space. Athletes, especially soccer players, are particularly prone to developing these symptoms due to repetitive trauma to the dorsum of the foot. Understanding these risk factors is essential for prevention and management. On-surgical management is the primary approach for anterior tarsal tunnel syndrome. This includes patient education, medications, local injections, physical therapy, and lifestyle adaptations. Rest and maintaining foot neutrality help reduce nerve compression, while anti-inflammatory drugs and corticosteroid injections can address persistent pain. Physical therapy is especially important for athletes, focusing on proprioception and strengthening perineal muscle. Surgery is reserved for cases where conservative treatments fail. Tibial nerve, TN, is susceptible to entrapment as it passes through the tarsal tunnel, located beneath the flexor retinaculum on the medial side of the ankle. Compression of the TN or its branches within this tunnel leads to tarsal tunnel syndrome, TTS. TTS is often overlooked and may be misdiagnosed as plantar fasciitis. The tarsal tunnel is a critical channel for nerves, blood vessels, and tendons entering the foot, making it a common site for nerve compression. Tibial nerve compression in the tarsal tunnel can result from trauma, foot deformities, obesity, systemic diseases like rheumatoid arthritis and diabetes, fibrotic changes, tendon inflammation, bone spurs, and tumors. Athletes with excessive foot pronation are at higher risk. Traumatic injuries and scar formation in the posterior ankle region may also precipitate TTS. Recognizing these risk factors is vital for early diagnosis and effective management. Patients with tarsal tunnel syndrome often experience pain and numbness in the medial plantar nerve area, affecting the inner side of the foot and the first 3 toes. Symptoms like burning or tingling may intensify at night or after prolonged standing. Pain can radiate and sometimes mimic sciatica. Objective findings include diminished sensation, reduced 2-point discrimination, and a positive tunnel sign. Swelling around the medial ankle may also be observed. Triple compression stress test, TCSD, also known as the dorsiflexion aversion test, is a valuable diagnostic tool for tarsal tunnel syndrome. This test involves dorsiflexing the ankle, averting the foot, and applying pressure to the tibial nerve, with symptom reproduction indicating a positive result. Additional diagnostic tools include X-rays, ultrasound, CT scans, MRI, and electromyography, which help confirm the diagnosis and differentiate TTS from other conditions. On-surgical treatment for tarsal tunnel syndrome aims to reduce pain, inflammation, and nerve stress. Strategies include modifying activity, using pain relief medications, and neuropathic pain treatments. Physical therapy methods such as cryotherapy, orthotic inserts, and stretching exercises can help. Strengthening exercises, kinesiology tapping, and night splints may also be beneficial. If conservative measures fail, surgical intervention may be necessary. Surgical intervention for tarsal tunnel syndrome is considered when conservative treatments fail and a clear anatomical cause of compression is identified. The procedure typically involves releasing the flexor retinaculum and decompressing the nerve's distal branches. Surgical outcomes are generally favorable when performed in well-selected cases. Careful assessment and patient selection are essential for achieving the best results. Medial plantar nerve, MPN compression commonly occurs near the navicular tuberosity, where the nerve passes through a tunnel formed by bone, soft tissue, and muscle. This condition is frequent in middle-aged runners, who often report aching or sharp pain in the medial arch of the foot during running. The MPN provides sensory and motor innervation to the sole and toes, making its entrapment particularly impactful on foot function. Running with the foot in a valgus position for long periods strains the MPN, risking entrapment behind the navicular tuberosity. Repetitive foot aversion may stretch the nerve, leading to inflammation and compression. Symptoms include burning pain, tingling, and aching in the inner arch, often worsening with activity. Tenderness behind the navicular tuberosity and reduced sensation in the sole near the great toe are common findings. Diagnosing medial plantar nerve entrapment involves a physical exam focusing on tenderness over the medial arch, from the abductor hallucis muscle to the navicular tuberosity. The Tinel's test, which involves localized pressure, is often positive and aids diagnosis. Gait analysis may reveal foot supination, which relieves pressure on the medial arch. Differentiating MPN entrapment from tendon pathologies is challenging due to the proximity of key muscle. Conservative management is the first step for MPN entrapment, including rest, activity modification, and avoiding rigid arch supports in running shoes. Anti-inflammatory medications and physical therapy can help reduce symptoms. If non-surgical treatments fail, surgery may be considered to decompress the nerve by releasing the fascia at the tender area. Careful candidate selection is crucial for favorable surgical outcomes. Medial heel pain may be caused by entrapment of the inferior calcaneal nerve, ICN, often resembling or accompanying plantar fasciitis. The ICN, a branch of the lateral plantar nerve, innervates the calcaneal periosteum, long plantar ligament, and intrinsic foot muscles. Entrapment can result from muscle hypertrophy, bone spurs, excessive pronation, or trauma. Recognizing ICN entrapment is important, as it may account for up to 20% of heel pain cases. CN entrapment is characterized by chronic pain localized to the plantar medial heel, with maximal tenderness over the nerve's course. Palpation near the proximal abductor hallucis or plantar fascia often reproduces pain. Patients may report tingling or electric sensations, and in advanced cases weakness in the small toes abduction. Electromyography and nerve conduction studies may not always detect dysfunction, making clinical assessment crucial. Conservative treatment for ICN entrapment includes heel cups, pads, and lifts to redistribute pressure, along with stretching programs for the Achilles tendon and plantar fascia. NSAIDs provide pain relief, and local corticosteroid injections may offer temporary relief. If conservative measures fail, surgical decompression may be considered, though complete symptom resolution is not always guaranteed. Setting realistic expectations is important for patient satisfaction. In summary, nerve entrapment syndromes in the foot and ankle are complex conditions that require careful evaluation and tailored management. Early recognition, accurate diagnosis, and timely intervention are essential to prevent permanent nerve damage and improve patient outcomes. Conservative treatments are often effective, but surgery may be needed in refractory cases. Understanding the causes, clinical signs, and treatment options empowers both patients and healthcare providers to achieve the best possible results.